Good day to you. The title of my presentation is Imaging in Thyroid Disorders, and I am affiliated to this organization. My talk is going to address the following issues. I'm going to discuss with you the available imaging modalities for imaging thyroid disorders. I will discuss with you some of the key advantages and drawback of each of these modalities. And I'll share with you some of the guidelines that I think is appropriate in making a choice of imaging regarding thyroid disorders. And we'll look at some of the common thyroid disorders in our environment and what are the imaging protocols that we utilize in order to image them appropriately. So, in terms of imaging the thyroid disease, there are two main types of imaging. We have the radiological imaging and the nuclear medicine imaging. The radiological imaging depicts anatomy, so they include things like plain radiograph, ultrasonography, CT scan, and MRI. This range of equipments or this radiological modalities provides you with anatomy as well as morphology of the thyroid. Whereas the nuclear imaging scans are the SPECT, and the common one that we know is the thyroid scintigraphy and optic. We have the SPECT CT, which is the single photon emission computer tomography, and we have the more PET CT, which is a positron emission tomography that looks at metabolism. So if you look at it again, the information that you get from these imaging modalities are either anatomical information or morphology and functional information. But these days, the good news is that we have a hybrid system where there is a combination of anatomical and morphological information that you receive from each of this modality. When looking at these modalities, it is also important to highlight this issue about ionizing radiation and non-ionizing radiation. Just remember, ionizing radiation is a radiation that is used to image patient, and this radiation has the likelihood or the effect of causing harmful effect to individuals that are exposed to it. Whereas the non-ionizing radiation has less energy, and therefore the likelihood of developing any abnormality or effect from ionizing radiation is less. So if you look at it, the ones in red are those that uses ionizing radiation. So they include PET CT, CT scan, SPECT, that is the thyroid scintigraphy and optic, SPECT CT, and positron emission tomography. Whereas the modalities that do not have ionizing radiation, therefore they are non-ionizing, they are ultrasound and magnetic resonance images. Those uses radiation, but the radiation that they uses do not ionize proton, and therefore the likelihood that they will cause any harmful effect is very less. So if we go back, I want to take each of this modality one after the other. The most common modality and the old modality that is being used is a plain radiograph. The idea of a plain radiograph, it gives you a two-dimension image of the thyroid, particularly, or of the neck. It gives you anatomical information. It is ionizing radiation. It gives you information on soft tissue and tracheal shift. If you look at this, you'll see that there's a soft tissue swelling in the anterior or the part of the neck, and you can see the lucency of the trachea, deviating the trachea to the contralateral side. It gives you information on calcification, on bony destruction, and of course, in patients with thyroid metastasis or patients with long metastasis from thyroid cancers, chest X-ray is also still very useful in determining the presence or absence of metastasis. So even though plain radiographs are no longer very useful in the initial assessment of thyroid disease, they find a good place, particularly when you're planning for surgery or when you're looking for metastasis in the chest. Thyroid ultrasonography is the most common radiological modality for imaging the thyroid, because it gives you a beautiful picture of the thyroid. You can see how it is. This is a non-ionizing radiation. Therefore, if you want, you can repeat it as much as you can without causing any effect to the patient. So it gives you the 3 to 4 dimensional imaging of the thyroid. If you look at this, this is the left and the right lobe joined together with the isthmic rope. It also helps you to assess the surrounding tissues like lymph node and the esophagus and other related neck relationship with the thyroid. So the thyroid plays a very important role. It gives you a morphology, and if you use a Doppler, it can also give you a blood flow to the thyroid. It is non-ionizing, like we said. It is readily available. But the drawback of a thyroid ultrasound is that it is operator dependent, and there is a high chance of high positive rate from ultrasound. Now, ultrasound gives you the position, the size, the capsule, the parenchyma of the thyroid tissue, and of course, blood flow. And like I said, it also helps you to assess lymph node. The thyroid, in terms of thyroid nodule, the thyroid ultrasound can be able to differentiate between cystic and solid lesions. And sometimes with nodules, there are some characteristics that you can be able to differentiate benign from malignant thyroid disease. So thyroid plays a very important role in diagnosis of thyroid disease because it also helps in guiding biopsy, the fine needle aspiration biopsy, and also plays a role in therapy because you can use thyroid ultrasound to aspirate cyst, and you can also use it to do thyroid ablation in so many cases. So you can see thyroid plays a very significant and important role in imaging thyroid and thyroid related diseases. Now, CT scan and MRI are three-dimensional cross-sectional imaging modalities that can give you a good assessment of the mediastinum, and it can look at extent of lymph node involvement, and it's also a very good tool in following up patients with thyroid cancer. CT scan uses ionizing radiation, therefore its use should be done with caution, whereas MRI is a non-ionizing radiation, meaning that you can repeat the examination as much as possible. CT scan provides you with a very good cortical bone, and therefore you can be able to assess bony structures much more than in MRI. MRI will look more of soft tissue. One of the drawback of CT is that it's MRI is that it's long imaging time, while CT uses a short imaging time. So these two important cross-sectional imaging are not used primarily for imaging thyroid disease, but they play a very significant role when you want to assess the extent of disease or when you want to follow up patients with non-thyroid cancers. Now, nuclear scans, like I said earlier on, the most common examination is a thyroid imaging, is a technetium 99M, and technetium portrays iodine, but the thing is that it is excreted. So technetium can be used to look at the functional significance of a thyroid tissue, and it can also calculate percentage uptake. Technetium, because it is not metabolized like iodine, can only be used to assess benign thyroid diseases, and therefore we image only the head and the upper chest. Whereas iodine 131 or iodine 123 is a radioactive form of iodine. This has the same behavior with iodine, therefore it is metabolized, unlike technetium that is excreted. And it tells you about membrane function of the thyroid. And no wonder why we use it mainly for imaging thyroid malignancy. And the good thing is that we can image the entire body, and this is useful in monitoring patients with thyroid malignancies. So for thyroid scintigraphy, this is the basic technique. The patient is injected with a radio tracer, in this case technetium 99, and this emits radiation which is detected by the camera, and you can see that this portrays the images of the thyroid. So you can see beautifully the thyroid. This is a normal scan showing the two thyroid lobes, the left and the right lobe. The good thing about technetium is that technetium nuclear scan is, apart from imaging, you also have the advantage of doing quantification. Quantification means that you can calculate the percentage uptake of the thyroid. You can also do a whole body images if you use iodine, iodine 123 or iodine 131, especially for patients with thyroid malignancy. So again, this is a normal thyroid scan. You can see beautifully how it looks, but more importantly, what I want you to take home from this slide is that we can do percentage uptake. The normal percentage thyroid uptake varies with the geographical location of individuals, but it is believed to be in most cases between 1 to 10%. So below 1% is usually terms as low uptake, whereas above 4 to 5% is regarded as increased uptake. So this uptake is very useful, particularly when you decide to do radioactive iodine therapy in patients with benign thyroid disease like Graves' disease. Again, iodine 131 is very useful in monitoring patients and follow-up of patients with thyroid cancer. It can help to detect residual disease or remnant thyroid disease. And of course, it can also help to monitor for the presence of metastasis from non-differentiated thyroid cancers. FDG PET is not a standard imaging modality for detecting thyroid disease, but sometimes as an incidental finding when we are imaging patients for other indications, we sometimes see thyroid nodules. And it is important when you see a metabolically active thyroid nodule to do an FNA, because the likelihood of nodule to harbor malignancy in this context is about 10 to 15% depending on the region of an individual. But what is important is that PET-CT is also very useful in managing patients with thyroid cancer, particularly patients who initially have a well-differentiated thyroid cancer and this cancer de-differentiates. So the role of PET-CT in thyroid disease is mainly in patients with dedifferentiation, and I'll show you some slides subsequently. So the choice of imaging in terms of thyroid disease largely depends on the patient age and the patient gender, the clinical presentation of the patient, the biochemical profile, particularly the thyroid function test, T3, T4, and TSH. And of course, in patient with thyroid malignancy, the TG of the patient is important. Another thing that will determine the choice of your imaging modality is how available the imaging modality is and how quick you can get it to answer questions. And of course, your experiences. Some people are experienced more with thyroid scintigraphy, others have thyroid ultrasound. So it is important in deciding what imaging modalities you have to do. But the key important thing is that before deciding on any imaging modality for the thyroid, it is important to know what is the most important clinical questions that need to be asked, bearing in mind those factors. Is it a benign disease or it is a malignant disease? So let's look at some of the common thyroid disorders that we find in our day-to-day practice. I'm sure the most common that we see is patients with thyroid nodule. This is then again, we have patients with hyperthyroidism and hypothyroidism, particularly in children, and patients who are histologically confirmed with thyroid cancer. So these are the four modality or four clinical questions that usually we encounter in our clinical practice. So thyroid nodule, ultrasound is the most important and best choice imaging modality. There are different algorithms that are used to characterize thyroid nodules, but the most common one that is used is the Thyroid. And this Thyroid tries to classify these nodules as whether they are benign or they are malignant, depending on certain clinical characteristics and clinical and features on ultrasound. I wouldn't go into detail of that. Now, thyroid scintigraphy for evaluation of nodule is only helpful if there is a suppression of the TSH. If TSH is suppressed, it means that we're looking for a hyperfunctioning nodule. And this is an example of a hyperfunctioning nodule. So in this kind of patient, they will have symptoms and biochemical evidence of hyperthyroidism. And there you are, you see a single focal uptake that signifies a single adenoma. Whereas in patients who are euthyroid, you will see sometimes you see a cold nodule. And a cold nodule on a thyroid scintigraphy carries a 15 to 20% likelihood of malignancy. So if I do a thyroid scintigraphy and I see a cold nodule, this FNA should be done in order to exclude malignancy. Whereas if it's a hot nodule, it means this is a hyperfunctioning nodule. The likelihood of malignancy is less than 1%. So the next question that most of clinicians would like to answer is in patients with hyperthyroidism, is this Graves' disease or is this thyroiditis? Usually the ultrasound, like I said, is the first modality of choice, but you can see that in this ultrasound, all that it will show in patients with hyperthyroidism, with Graves' disease and with thyroiditis will be almost the same picture. The thyroid will be enlarged, it will have quasi-echogenicity, and there will be increased blood flow. But thyroid scintigraphy is one single modality that you can use to distinguish between patients with Graves' disease and patients with thyroiditis. In patients with thyroiditis, because the thyroid is acutely ill, it is unable to concentrate iodine. So when you do your thyroid uptake scan, there will be absent uptake. Whereas in patients with Graves' disease, because there's hypertrophy and hyperplasia of the follicular cells are hungry for iodine. So if you give pateknitide, you can see that there's intense uptake, bilateral and homogeneous. So this is the two distinguishing features imaging-wise using technetium to differentiate between Graves' disease and thyroiditis. Again, this is important because this differentiation is important because patients with Graves' disease will benefit from radioiodine therapy, and we see how radioiodine therapy is administered in patient. Whereas patients with thyroiditis, there is a evolution of the disease. Initially, there will be absent uptake, but over time, you can see that there is some degree of uptake as the patient evolves, the disease evolves. And after some time, usually after 1 year, you will see that there is a return of a normal uptake. So this is the evolution of how patients with subacute thyroiditis will look like. And this is important. Again, history is very important, timing is very important, and the clinical context of the patient, like I said earlier on, is very important, is a key important factors in deciding the interpretation of particularly thyroid scintigraphy. So in patients with multinodular goiter, particularly patients with toxic multinodular goiter, thyroid scintigraphy may play a role. You can see here that the thyroid is enlarged and it shows ill-defined, inhomogeneous uptake. If you look at the thyroid ultrasound, again, you can see enlargement of the left thyroid lobe compared to the right thyroid lobe. This is further confirmed by the thyroid scintigraphy. So again, thyroid scintigraphy may not be the first modality of choice. Ultrasound is always, particularly in patients with multinodular goiter, because then it can help you and assist you in looking at the size and nodularity, and it will choose a nodule that is suitable for biopsy in order to exclude the possibility of malignancy, because patients with toxic nodular goiter have a 5% likelihood of developing thyroid cancers. So in congenital abnormalities, or imaging, particularly in children, this is the time when most of them presenting with hypothyroidism. The importance of imaging is to be able to diagnose if this patient has a genesis or a sublingual thyroid or a thyroglossal cyst. So hypothyroidism is one of the presenting clinical complaints. This is unusual in adults. Usually we don't do so much of imaging of the thyroid in patients, in adult patients with hypothyroidism. So these are the common features that you see in intense. If you see an intense uptake in a pediatric patient that looks similar to something that you see in Graves' disease, then this is likely, and with the hypothyroidism, this is likely a thyroid dyshomogenesis. And this is a patient you can see with a sublingual gland. This is projected on the lateral, and patients with thyroid agenesis, and a patient with thyroglossal cyst. So these are the various imaging presentation on thyroid scintigraphy of neonates with hypothyroidism. Another example is a child with hypothyroidism, and you can see here the thyroid ultrasound shows the right thyroid gland with the normal size, normal echogenicity, but there's an absence of a left thyroid gland, and this is thyroid hemogenesis in this patient. And you can see that this is further confirmed with the thyroid scintigraphy. There's an absence of the left thyroid lobe. So in malignant thyroid disease, the imaging modalities that are done for evaluating malignant thyroid disease is different from those that are used for benign. Like I told you earlier on, in patients with malignant thyroid disease, we do radioiodine, and iodine can be iodine 123 or iodine 131. This is administered orally. It is not administered intravenously. And the thing is that you can do a whole body imaging. So this is a normal whole body imaging of a radioiodine scan in a patient with thyroid malignancy in remission. So you can see that there is absent uptake in the neck, and there is no any evidence of nodes. There is normal uptake and distribution in the stomach and the urinary bladder. So this is a normal radioiodine 131 or 123 scans can give you the same picture. So the usefulness of iodine 131 in therapy is in patients with post-thyroidectomy ablation. So the imaging helps to look for thyroid remnant tissue or to look for remnant disease, because this is important to help in following up patients, and it also improve or in the specificity of TG, which is used as a tumor marker in patients with well-differentiated thyroid cancers. So the indication for whole body in patients with thyroid diagnosed with thyroid cancers, first for post-thyroidectomy ablation, and follow up if suspected for reoccurrence, especially if there is a rise in TG. We can always do a diagnostic scan, or we can use it to treat patients and do imaging after the treatment of metastatic thyroid disease. So these are a few examples of iodine 131 whole body scans. You can see in normal patient, like I showed the earlier on, you can see that there is absent uptake in the neck, and there is no any evidence of iodine uptake outside the med. This is uptake in the bowel. So this patient is normal. This patient is considered to be in remission. Now, for patients with reoccurrence, you can see that there is a huge thyroid tissue in front of the neck, which is radioactive, and this kind of presentations, the patients will do very well on radioiodine therapy. This is a patient with widespread metastasis. Here you can see that there is uptake, remnant thyroid tissue in the neck, and there are multiple uptakes within the lung. So this is portraying patients with lung metastasis. Again, these patients will do very well with therapy because these tumors or these tissues are radioactive, and therefore you can use radioiodine to ablate them. Another example here, you can see this is a post-thyroidectomy imaging. You can see this is post-thyroidectomy scan, and it is something called the star phenomenon, and this indicates that there is good ablation. This is the front, and this is the back of the patient. Again, there is no evidence of metastasis to the rest of the tissue. As contrast to this patient on the right-hand side, where you see a huge thyroid remnant tissue, but then there are multiple radioactive iodine avid tissue in the lungs, in the soft tissue. All right, so this is portraying a patient with a remnant thyroid tissue and multiple metastases to the lung and subcutaneous tissue as well as bone. So PET CT, like I said earlier on, uses glucose as an analog. So it's a glucose analog and goes to any area where there is increased glucose. And that's why you see the brain utilizes glucose much more than any other organ in the body, as well as the heart itself, and there's excretion in the kidney. So we use PET CT to evaluate patients, and sometimes, like we said, we see incidental findings of thyroid nodules in patients. But more importantly, PET plays a very significant role in following up patients who are known with well differentiated thyroid cancers that has de-differentiated over time. And therefore, the most common clinical questions that we have is a patient with a rise in TG and a negative iodine 131. So the clinical indication for a PET in patients with thyroid cancer is if you have a rising TG with a negative whole body. So this is an example of a patient with a rising TG, but you can see the radioiodine did not reveal any abnormal uptake. This uptake is excretion in the bladder. But you can see that again, there are different types of imaging that we can do. In the olden days, we used to use something called MIBI and octreotide, but these days we use FDG. So this is an example of this is an example of an 84-year-old heavy smoker with a Tennis syndrome. So we know the Tennis syndrome are those patients with elevated thyroid TG and negative radioiodine scan. So the patient has a persistent elevation of TG, but the radioiodine scan is negative. And if you look at this, you can see that there is huge uptake in the mediastinal area on the FDG PET. So what has happened is that patients who have well-differentiated thyroid cancers, the sodium iodide symporter gene is still present, and therefore they can trap iodine, and therefore you can use radioiodine. But as the case becomes, or the tumors lose the sodium iodide symporter gene, there's then a flip flop. So there is now, instead of uptake of iodine, there will then be uptake of glucose. So that's why FDG is a very important tool in monitoring patients who have elevated TG with a negative whole body iodine scan. So imaging, as far as we're concerned, like I said earlier on, depends largely on the clinical indication of your patient. But again, there are so many things that are evolving this day, and I will not conclude my talk without telling you what is happening currently in imaging of the thyroid, particularly the use of AI in imaging thyroid. There is deep learning algorithm. This helps to differentiate between benign and malignant thyroid nodules. It also helps AI in future can help planning for thyroid surgery. So the importance or the benefit of AI in thyroid imaging will be to reduce unnecessary biopsies. It will help to minimize and help minimal invasive surgery, which means that you will have a better patient outcome. It is a very important tool for teaching and for research. So in summary, imaging plays a very significant role in the management of thyroid disorders. But like I said, the choice of imaging modality should be guided by the clinical context, the biochemical profile of the patient, and also keeping in mind, as always, the harmful effect of radiation, particularly if you are using imaging modalities that have ionizing radiation. But at this stage, I will say that thyroid sonography or thyroid ultrasound remain the most viable tool and the first line imaging modality for thyroid disorders. And over the years, there's improvement in imaging tool. We are becoming more powerful. These equipments are becoming more sophisticated, and AI is also adding new technology. So in the future, you will find that there will be advancement in tracer for your nuclide scans, and the technologies, of course, will improve, and we'll be able to use those imaging technologies. But ultrasound will still be here with us. It's the gold standard for imaging of all thyroid diseases. So, however, like I said, that imaging should be looked at as complementary, and we should not use imaging or should not replace imaging with our clinical assessment. After years and years of imaging the thyroid, I can always say that a good clinical history, a meticulous clinical examination remains the best way to arrive at a diagnosis, particularly of thyroid cancer, the thyroid disorders. I will never interpret a thyroid imaging without looking at the clinical context, without looking at the biochemical profile of the patient. So we should look at imaging as as an imaging interpreter, I always do that. And the best way to evaluate our patients is a better clinical examination, a good clinical history, combining with your imaging modalities, which is complementary. Thank you very much.